better sleep, sharper focus, a healthier life. It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise,
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
You guys, thank you so much for joining us on No One Told Me, the Airway Health Connection podcast. I have my dear friend and colleague, Dr. Amanda Vanderstelt of Aligned Orthodontics here in Denver. And I am just so excited that she could take time out of her day of helping kids and adults have better foundational stability with their jaws to talk to us today. So, Dr. V, why don't you go ahead and tell us a little bit about where you're from, how your philosophies have shifted over time, and tell us a little bit about Aligned and the foundation that it was built on.
Thank you, Liz. Yeah, Liz is amazing, and I'm honored to be on the podcast. So I am very passionate about a lot of the same things that Dr. Turner is. She's more of a guru on baby tongue ties. I'm not, but it all leads into what I do. So I'm originally from Kentucky, born in Michigan, big Michigan fan, go blue. But as a very young child, I had airway issues, didn't know I wanted to be a dentist, thought I wanted to be a plastic surgeon. So I always enjoyed, I very much, my mom had cleft lip and palate, so I was very aware of the face at a young age and how much it impacted self-confidence and just breathing, because my mom had a lot of breathing issues with cleft lip and palate, as well as dental issues. So for me, that was an awareness I had. I thought I wanted to be a plastic surgeon, and then changed just a bunch of a bunch of events that ended up bringing me into dentistry. I had a mentor that I randomly met, and he happened to be a very comprehensive orthodontist. And he's the reason that I actually went into orthodontics. And then as time went on, I realized in orthodontic residency, that part of the way that I grew might have been related to airway issues I had as a child. So I had really big tonsils and dark circles under my eyes, and I ended up growing pretty long and narrow, which created a lot of recession in my mouth and poor nasal breathing as an adult. So for me, I was very curious, and I'm just a very curious person that always looks at root causes of everything. Like, I have to know why. So it comes back to bite me with my kids. But anyway, so for me as an orthodontist, as I got into my career, very early on in my career, probably 2 or 3 years in, the topic of airway and as it relates to the jaw structure really entered my profession, the orthodontic profession. So, I mean, this has been around, and we have been looking at this as humans for many, many, many years. But then it kind of lost interest, if you will, in the orthodontic profession. And, back in probably 2012, 13, it really started to regain interest. And so as soon as I started going to conferences that just connected the dots, I gained immediate curiosity and interest because of my own personal experience. But then also just as it relates to understanding more of the why. Why do some people grow like this? When is it genetics? When is it something else? And the more you start unraveling, pulling the string, the more you unravel the sweater. And you just, I'm obsessed with health and wellness in general as it pertains to every pillar of health with our body. And I think sleep and airway, I've discovered over the years is just such an important pillar. And so of our wellness. And so it's interesting, I did not become a plastic surgeon and I didn't go that route, but to be able to potentially impact someone's health beyond teeth, to me, is even more fulfilling. So, it's not that I do it for me because I like doing it. It's because it's just, I think, helping people way beyond just straight teeth, which is wonderful in and of itself. But that's where I landed here. I came out to Denver for my residency, and I did a few different career opportunities. I worked in private practice with a general dental group for a while. So I did that for like 7 years. And I've been practicing for, I guess now 11 years since I graduated. But, I just really realized that is known to be such a healthy city. And I found that there were I just think that the dentists and orthodontists in Denver, we kind of were heading in the direction of learning airway together. And so as a community, I decided to own my own practice or open my own practice so that I could really just bring the most comprehensive orthodontics, including, how airway relates to our jaw structures to Denver for both kids, well, not just kids and adults, but everything in between. And so I really just wanted a place where if I were a mom who's not an orthodontist, but I was into health and wellness and I wanted to bring my kids or myself to get better, a lot of times practitioners get very tunnel visioned. I wanted them to have a place where they know that I'm on the forefront of pulling all of this together and giving them what I believe to be, the most comprehensive care that they could possibly receive. Also, like working with people like you, where I'm very collaborative because you cannot treat a system just with one specialty. You have to have many, many people you lean on like you. So
Absolutely. Well, we got here for a reason, right? And so for those of you listening that are kind of understanding and beginning to understand how orthodontics impacts breathing, if we think about it, our jaws are our breathing tubes, right? So the roof of the mouth is the floor of the nose. The more wide and forward the upper jaw is, the more passive the nasal breathing can be. And the more forward the lower jaw is, the more open the oral airway can be. So we really need, like Dr. V said, the system to be functioning together. So we need to appreciate where the bones are, the teeth are, and the soft tissue. And for those of you listening that don't know kind of about some of the controversy in orthodontics, there has been a practice for many, many years of extracting permanent teeth to line up other teeth. And I would say, and I know many of us would say, that it's not the orthodontist's fault that those teeth needed to be pulled. It's that we got to that child too late. They were already developed. So for you, I mean, you're treating growing children, right? You're working a lot in phase one intervention to allow for better structural stability long term. So what's kind of the bread and butter of your practice? Who do you like seeing? Where do you see opportunities that others could be missing?
yeah, I guess so. My niche, I would say, is just that I'm very comprehensive with a focus on how this works as a system, right? And of course, beautiful teeth. So the tricky thing is that, like, I don't just see kids, I don't just see adults, because all of this starts very young. So you see babies, and this, I've even been told by you and many other people that all this really starts even in utero, right? And I won't go there, it's not my expertise. But so the tricky thing is, even on a 2, 3-year-old, 4-year-old, you might start to already see airway issues, maybe enlarged tonsils, adenoids, the jaw is also narrowing. Now the tongue is having strange compensations, right? So all of this system can get dysfunction very quickly. I have a history of doing a lot of really complex adult cases, and I love those. But the more that I did crazy complex cases on these adults and saw so much damage, my mind just kept thinking, gosh, if I had seen this person when they were younger, what could I have done? And I was treating kids too at this point. But what really made me passionate about the very young kids is simply, so, like you said, so much becomes irreversible on an adult, but not just their jaw structure and their airway, but their teeth. Their teeth have so much more damage. They are so much more prone to acid reflux, grinding, and chipping teeth. And, like my generation and older, especially the generation right before us, people in their 50s, that damage really starts to show up. So the more I was doing a lot of jaw surgeries, I started doing a ton of like orthodontics to set up for jaw surgery. The more I really became prolific at that and passionate about that, the more I even became more passionate about younger kids. And so typically orthodontists, we have this saying, I don't say this anymore, just to be clear, but 7 and up. People even bring 7-Up bottles to their referring dentist, right? They say, "Oh, just bring your kid at 7." But at 7, now, because of my focus in airway and how much I see younger kids too, I'm about 50-50 adults and kids. And then of course teens kind of in the mix too. So young kids though, 7, so when it comes to jaw structure, there can actually be some irreversible changes that unfortunately I cannot change on a child, especially the vertical growth. So like width, sure, on a 7-year-old, yes, you can widen. But the other thing is you have all these teeth growing underground. So if we see so much recession in my generation and above, so much gum recession where like the roots start to get exposed. You know this, but for anybody listening, not in dental. So, and I think we have just come to just like the generation of my grandmother, where they just come to accept that they were going to be indentures. Well, I think our generation has just accepted, oh yeah, we have recession, right? Like everybody
Yeah.
has recession.
Yeah,
But why?
my parents
Why?
need a gum graft, so I need those because they're genetic. I'm like, well,
Yes.
like
Right?
kinda, like biotype maybe, but structure is what matters.
Yeah. And so, what I've realized is I've talked to orthodontists who are like, oh, I have a surgeon come in my practice because we do so many canine exposures. I'm like, really interesting. I don't have many. I get some because if they come to me too late, I get canines that are impacted. But one of the things that I'm doing is I try to prevent the 10 car pileup. So you can do orthodontics on an 80-year-old and you can wait. You can do it on a 50-year-old, a 40, a 30-year-old. But it's going to look different and it's going to look much better if you start earlier on a child who needs it,
Mhm.
if they're already showing signs of jaw structures being too small. Because then if you start developing while teeth have not already started going in the wrong direction, twisting, turning, if you develop and widen or develop in whatever direction during that, teeth will often start drifting into more of a normal place. And then you will see that they start to come in into a more aligned position, more into the center of the bone. The bone, the face isn't growing as long and narrow. Hence, then you're not seeing as much recession if teeth come into the middle of the bone, into the right place. And the body isn't having to reserve its bone by growing narrow and long. Instead, it can grow normal proportions and have thick bone and thick gum tissue. And all of that determines what happens to your mouth as an adult. Also, if we're developing young, the airway can respond better and more favorably. You might get more favorable nasal passageway opening versus like the later you expand on a child, we know that the nasal passageway on average, everyone is different, won't widen as much, which is a huge thing. This is a huge topic in and of itself that I think is we could spend a lot of time on, but we really want great nasal passageway opening. You look at these, skulls from different times when diets were more natural and there was less inflammation of living in a society, living as humans. And these nasal passageways are massive. They are massive. And humans, we know the nasal passageway and the jaws are getting smaller and smaller and smaller. And that's creating restriction in airflow. We are supposed to breathe through our nose 99% of the time.
Well, and
So,
what I tell families too is that our environment, like you said, there are different time periods where we didn't have as much inflammatory factors. We live in a society where there's so much pollution. Our kids' lymphatic systems are working overdrive. So they really need more structural space for breathing. It's not the only thing. And that's, we're structuralists, right? We're looking at the
mhm.
structure and we're looking at how that can be modified to help the growth of a person to reduce symptoms in the future. Because how many of our 50, 60, 70-year-olds have sleep apnea that's just
Mhm.
become diagnosed when they've been symptomatic for years? I think we're looking at kind of how we can biohack our own health and our children's health so much more closely and comprehensively now because we just have more information. So I wonder, and I don't know the answer to this, when was that recommendation by the American Academy of Orthodontists to assess by age 7 made? Is it old? Is it?
It's old.
It's
It's
old. Yeah.
old. Yeah.
Because, like teeth are starting to, I see a lot of delayed eruption these days. And I would imagine you do too, because there's just not great space. And the way I describe it to patients and parents is like the grown-up teeth are like Pac-Man and they're eating away the roots of the baby teeth. And when there's not room for Pac-Man to fit through there, we're just going to see retained primary teeth. So not only do I hear like in the age 7 thing. I mean, I think that's a societal recommendation. So it's a good idea for us to, even for kids where parents don't suspect anything for it, because many dentists aren't referring to orthodontists by 7. what I hear a lot of is, oh, we have to wait for all of your adult teeth to come in. And for a lot of these kids, that's really, really late because they're just not exfoliating as quickly as they should. So I don't know. It's a hard uphill battle when you start to bring in the word airway, but really all you're doing is orthodontics, and you're
It's
doing
true.
it comprehensively. Like you're moving teeth. You're treating a dental problem, and the really cool positive side effect is you're helping people's airways and general health be better when you're treating the dentistry. So,
Yeah, I think, I feel like there could be a podcast of dispelling misconceptions.
yeah, we should do that
Of
sometime.
Yeah, that would be really fun. Just like hitting up about having a list and just hitting them up because like you said, I think, everybody has different eruptions genetically. There is definitely that. I mean, I have a few 9-year-olds in my practice that have all of their adult teeth and just, rule of thumb, most kids have all their baby teeth gone by around 12. But that can vary, of course. But so many people, when their jaws are small, and like you said, if their teeth just don't have room, they don't come in as quickly. Oftentimes, the front teeth, especially because now they're trying to resorb and eat away two baby teeth. So
Mhm.
it slows the process down. Or, like on the bottom, we see teeth come in behind. And a lot of pediatric dentists will say, oh, that's a normal awkward phase. It's actually not. It is a sign that the teeth couldn't resorb. They didn't have room to resorb the baby teeth. So they went in a different direction where there was a path of least resistance. And that's why they came in like that. And yes, if you extract baby teeth, adult teeth will kind of like drift and straighten out, but it robs Peter to pay Paul. It robs space from other teeth down the line that will come in. So, as far as aging, I'll touch on this really quick if you don't mind me touching
Sure.
on that. I never, like, it's funny because I have quite a few orthodontic friends that are not airway focused, and we just have very open and honest conversations about this. And I call them, they're more like teeth orthodontists. They just change the jaw if they need to move teeth around, or they extract teeth because they're just focused on the teeth and not the bigger picture in the system. But, so my point being, what I was going to say is I never set out to treat young kids. Like, in fact, I have 3 kids myself, and I know how hard it is to work in their mouths.
Mhm.
But a 4, 5, 6-year-old, they can, patient management wise, be really tough. Their parents might wonder, well, why are kids getting braces so young these days, right? But again, you just have to understand a few things. I always say that the jaws are the foundation of the developing airway. I mean, the upper jaw is literally the same bone that makes the side walls of your nasal passageway and the floor. So it's basically making the inside of your nose. It's the same jaw. Then below, the upper jaw makes the house for your tongue. If your upper, lower, or both jaws are too small, that is the house that your tongue has to live in. And your tongue does not grow a smaller size if your jaws grow too small. And I
Mhm.
don't think that people realize that parts of our body have independent growth, like our septum,
Mhm.
like the cartilage of our septum. So if our nasal passageway is growing too small, the septum can deviate very, very early because it's just growing. It's just taking its genetics and doing what it needs to do. So if I have a young child, I have kind of a process that I've created for this because I get a lot of phone calls of 2-year-olds and 3-year-olds, and I'm like, I'm not putting an expander in a 2-year-old. Not yet. I'm not ready for that. Maybe there's people out there, I'm not doing that yet. So if I have someone who is under 6 right now, like 5 or below, we always make them see an ENT first. We just have them go and get their adenoids and their tonsils checked out because otherwise I'm doing it. And if they're really large, touching or whatnot, then I'm saying go to the ENT. So I'm really screening for my ENT, which I'm happy to do that. But I just have them check that out first. And it's not that large tonsils and adenoids are necessarily always like the first root cause of why the jaws are small. In fact, it can be really hard to know which came first, chicken or the egg. Where did the inflammation start?
I think it starts like the day they're born because
Yeah.
their turbinates are too big, and then they've got reflux as a baby, and everybody dismisses it. And then
Yeah.
can we also touch on kind of how, because this is something that's always jaw-dropping for parents when I talk to them, how adenoids and tonsils influence growth. And because I think people aren't understanding why tonsils can lead to certain profile, and adenoids can lead to a certain profile. And I think a lot of parents are very, very resistant towards surgical intervention because they're not truly understanding the
Yeah.
impact that it's having that's negative. They're like, well, we'll just wait to do the expander. It's like, well, we already missed 3 years worth of growth we could have optimized. So can you speak to
Okay.
that a little
Yeah.
bit?
Okay. So I'll first just explain like how this happens, but then I'll kind of touch on the how I approach this because I
Yeah.
think a lot of people in anything, anytime you're dealing with the whole body and a lot of systems in medicine and dental, you kind of do have to have some sort of algorithm. And then, of course, every human being, there are variations, and that algorithm needs to be individualized. So, starting off, let's just say that now, kind of we're speeding up, a patient has enlarged adenoids. Adenoids are kind of like tonsils that are right behind your nasal passageway. They also are next to the eustachian tubes. So, literally, if adenoids are inflamed, picture that you have a cut, a really nasty cut. Maybe it's infected and red and yucky. That is like the tissue, okay? If it's inflamed, your adenoids. Your eustachian tubes, which connect to your ear canals, are right next to that. So there's just tons of inflammation sitting there. So there's a lot of things that are going on. One thing now is that if they're big, they're just harboring bacteria or a virus or both, and the body can't heal itself. Now, secondly, the nasal passageway, again, we're supposed to breathe through our nose 99% of the time. Now, a kid is not getting passive quality airflow through their nose. Okay, so if a kid cannot breathe passively and easily through their nose 99% of the time, then now the body is very smart. It will keep you alive, fortunately. So it's not just going to keep the mouth shut and let the air slowly dwindle and let you die. It is going or get brain damage from lack of oxygen. It's going to open your mouth, which is literally a backup hole for air for survival because that is how important breathing is. So now this is the part that people probably don't know. When the mouth is open, our body is so adaptive, not just to keep itself alive, but to also be able to chew so that we can sustain ourselves, that the teeth and the jaw will try to move towards each other so that your bite can stay together so you can chew. Because if your teeth don't touch quite right, it's harder to chew and it's harder to have sustenance and to nourish our bodies.
And
So
it's
our
interesting too.
body,
I hear a lot from parents, and he can't chew with his mouth closed, and he's such a messy eater, and takes so long to eat, has to take so many breaks. It's like, well, that kid can't breathe while they're
yeah.
chewing. They can chew, but
Mhm.
it's going to take them a long time, and it's going to be very disruptive. But you don't know. They don't
That
know. They
is a
don't
good
know any
that's
different.
a good gauge. There are different ways to tell if your kid can breathe through their nose. Like even if it's not great passively, one is to watch them eat.
Hmm.
If they can't take a breath and try this on yourself. Like if you can eat and you're breathing through your nose while you're eating, or do you have to kind of stop and we do this thing because it's from childhood and we don't even probably know we're doing it, but test yourself. If you have to breathe through your mouth while you're eating, you don't have good nasal breathing.
Hmm. Hmm.
If you're congested, you'll notice that, and it's uncomfortable to eat. So with kids, yeah, that's a good test. You can also like have them, like run down the hall for like 4 times and see if they can keep their mouth closed and breathe through their nose. I know my myofunctional therapist has a test too, but there's a lot of tests. But I mean, essentially, you should be able to breathe through your nose when you eat.
Yeah, and
Um,
don't just tape their lips shut at night to do a test because that's something
no,
we hear a lot.
no.
They're like,
Oh
should I
my gosh,
wait? I'm
that's
like, absolutely not. Like, you're a grown up, you know you can breathe through your nose. Your 3-year-old has no concept that they can or they can't. So
if
not a
you
safe
have
test.
blockages in your nose. So
Ugh.
back to the adenoids. If the adenoids are inflamed, the other thing too is that bacteria or virus or both that are just kind of like sitting in there or whatever irritant that can't resolve itself, that inflammation, it's all connected up here. It makes its way to the turbinates. And oftentimes we see that the turbinates, which on both sides of our nose, we have like essentially two that you can see here and here, the middle and the inferior on both sides. And then there's higher up ones if they're there. But essentially they're meant to swirl the air and then they're covered in tons of mucosa, which then absorbs oxygen, filters the air, and moisturizes it. So turbinates are really important. And it's important that they're there, but if they're too big, it again harbors inflammation and prevents air from passively getting back. So all of these points are all connected that now your child can't breathe through their nose. So then now you're mouth breathing. Mouth breathing, unfortunately, further perpetuates this cycle because now the air is going right back. It's not being filtered before it enters your body, it's not being moisturized. And the oxygen isn't being absorbed by your turbinates. So now it also hits your tonsils and it hits the bottom of your adenoids as well and can further perpetuate more inflammation of the tonsils and the adenoids. And so it's just this vicious cycle. Now the adenoids are getting, and it's not that every kid who mouth breathes has large adenoids or large tonsils or both, because there is a genetic component.
For sure.
And there's also all of
And
the
environmental. There's
environmental,
environmental.
I was going to say,
Yeah.
mold and
Yeah.
toxins.
And for,
Yeah.
you got a 1-year-old whose adenoids are big. These lymphatic tissues, like this is the immune system developing. They're gonna get bigger over time. They're meant to get a bit enlarged because it's the body learning what to fight off. So in I think one thing people don't often understand with surgical is like when you're doing adenoidectomy, it's really a misnomer. They can't remove all of the adenoids. Adenoids can grow back. The goal is to just get that kid breathing better when necessary surgically. And same thing with tonsils. There is the approach where you could remove partial, but the hard part is tonsils can also grow back. So, and I think if any ENTs are listening to this, there's a huge argument that mouth breathing doesn't cause tonsil and adenoid hypertrophy. But I would disagree that the cycle of breathing and all of it that goes with it can absolutely exacerbate. May not be the only factor, but mouth breathing is a big player.
Yeah, I agree. Exacerbate it. And I think that's where every individual might have a baseline of environmental genetics. You'll get a parent that says, well, my tonsils are still big and everyone in my family's tonsils are big. And my ENT does tell me that there is some kids have a more genetic predisposition to having a bigger reaction, just meaning that they get more inflamed than other kids. And so, yeah, every kid's so different. And that's where, I think with orthodontics and how do we approach this, it's helpful to have an algorithm. And that's where, like, Audrey Yoon wrote her amazing paper about how you approach pediatric sleep disorder breathing. And that was very needed to help people understand, how do you go through this? How do you make sense of this? What do you start with? Do you start with therapy? Do you start with mouth taping? It's so hard for a parent to know that. But ultimately, you really need like an orthodontist and airway focused dentist to be able to look at this whole picture and then knowing the most ideal kind of algorithm to approach this with every aspect of what makes this kid individual. Now we approach it like, okay, for your particular child, this is how I would go. Maybe, okay, if it were my kid, yes, if the tonsils are touching and the adenoids are massive and they have a lot of symptoms where they're not thriving, at school during the day, or they're just not sleeping well, they're not rested, then sure, I would recommend ENT first. But then they're going to need expansion. Then we need to start working on getting the structure and the neuromuscular more on track, right? Getting the structure, orthodontics, widening jaws, moving teeth, widening the nasal passageway, then maybe myofunctional therapy or, addressing the tongue, getting the breathing pattern, the neuromuscular to now use its space as it should, because if it hasn't been functioning normally for so long, it usually doesn't just start working normally once you idealize the anatomy.
And that's the hard part too that I run into a lot because, I manage a lot of structure, I manage a lot of soft tissue structure, and we get a lot of really well-meaning referrals, either self-referrals or from myofunctional therapists saying tongue tie release to help with speech and sleep and solids. And then I look at the jaw and I go, goodness gracious, there's a reason all these things are a factor, and it's because the skeleton's a problem in this kid. And it can be ill-advised to do tongue tie releases on a 4 or 5-year-old if there's not space, because A, we're not going to gain much, and B, like we're already that space for that tongue is already compromised. Now we go and let it go and it doesn't have the strength or the ability to live anywhere else because there's just not room. So that's where, kind of where you're co-managing with ENT, we're co-managing with ENT orthodontics, just because the whole thing is such a system and we can't do it all in isolation, like you said.
Yeah. And I think some other things that, parents have seen that I kind of want to maybe not necessarily dispel, but touch on is, we talk about, if you haven't heard this yet, Dr. Turner and I talk about this a lot, but the tongue is besides talking and chewing, it is meant to help develop the palate, the maxilla. The palate is just what we refer to as the roof of the mouth, essentially, right? It's the housing of, but the maxilla is a bone that goes all the way up to the nasal passageway. It's a large bone, and that whole maxilla needs to widen oftentimes on kids. So when we're talking about, okay, what are some things that you can do with a young child? Well, first, I think you need to look out for signs and symptoms of airway issues, of course. Like, is your child not sleeping through the night? They're waking up, they're restless, they have dark circles under their eyes, they are mouth breathing, snoring, um, open posture, like mouth posture. You're seeing that. These are all signs that something's off with this system, right? If you just throw all of a sudden, sorry, I was like nose tape. If you throw lip tape, you start lip taping a child without a proper diagnosis, you can do more harm because you don't know where the restriction is. You don't know where the problem is, right? So then there are other things like appliances that people are getting either through a dentist, or I don't know if you can even buy them online too, but they kind of look like
Sure
a mouth
can.
guard.
Sure can.
They're rubber or silicone. And what they're meant to do is they're meant to basically help a child nose breathe and get the tongue in the right place.
Well, and
Okay.
they're advertised to be orthodontic appliances.
Yeah. So, yeah. And I don't even know if I should say the names of any of them on
I
here. Like,
wouldn't,
okay.
but they're
So
guided growth
they're
appliances.
guided growth appliances. And, the intention is great. And there is a time and a place where they can be an okay appliance. Like after expansion, if you're trying and you know that the nasal passageway is clear, a kid can breathe through their nose, that their tongue can get to the roof of their mouth. It can be an okay thing in some time and place. But the tongue, if there's already dysfunction and the jaws are already narrow, just by doing myofunctional therapy or by wearing one of these appliances, the tongue cannot widen the maxilla fully to get it back on track to open the nasal passageway, to truly widen the maxilla at the level of the bone, not just tipping teeth out, because that is different. These appliances don't truly do that. And that is one thing I get questions about all the time in my practice. Well, what do you think about this appliance? Or we've been wearing this appliance for, gosh, like 3, 4 years. And now, someone said maybe you should do an expander. It's because they don't truly expand the maxilla, you guys. You have to, unfortunately, so just kind of like some general guidelines. So the youngest I typically expand is 4. And there has to be a very good reason to do it. The child also has to be emotionally ready. We do readiness
And
checks
a
in the
reason to
chair.
do it could be
And
that you send them to ENT, they're non-surgical, because you co-manage these a lot under the guidance of ENT as well. So
yes,
it's not like you're like, let's just throw an expander at them. Like there's very, very good reason to be doing.
they still have to have airway symptoms. I mean, it would be
Absolutely.
really typically, I mean, I can't even think of a single one that I've ever expanded on a 4-year-old that didn't have airway symptoms.
Well, and
That's,
that would be the argument too I would
yeah.
make for guided growth appliances. Like you and I have shared a case where it was a little girl with a really, really deep bite. And her deep bite, she wasn't really an airway kid, but they wanted to do something and it helped with posture and habit. And it set her up really well for success for true phase 1 with you.
Yeah.
But it bought some time until she was ready and it was necessary. But yeah,
To
so
your
that's
point,
where.
you are very qualified to actually be looking to see, well, can she breathe through her nose?
Mhm.
And can she be using this appliance? I think when people don't have that initial diagnosis by a properly trained airway dentist or orthodontist, and they're just using these appliances and they have no idea, then they fail, right?
Well,
So
yeah, and that's
there
my
is a
plug
time and a
for I
place.
love Myo Munchies just because they're very patient guided and there's a handle on them. They can take them in and out. Like it's not and they're not meant to be or I use them as habit appliances and also as a test. Like, can this kid breathe?
Yeah.
Especially for parents that are really resistant to going to the ENT. I'm like, let's just see if your kid can use this. And when they can't, we know
Hmm.
that your next step has to be ENT. There's no other option. And so it helps the parents kind of comprehend what they're seeing a little bit better because they don't think their kid's mouth breathing, but their kid's just sitting there with like a gentle lip bar, and
Yeah.
you can hear it, but they can't hear it because they see it every day. So, so
So,
yes, you'll expand a 4-year-old. Can you talk to
yeah.
us about? what your kind of conversation with them would be risk and benefit. Like the benefits are XYZ, the risks are probably going to need more work because we're making up for lost time, stuff like that.
Yeah. So it is rare that I expand a 4-year-old. Like they are not the majority of my practice. Okay.
Mhm.
There has to be a really good reason. And it's usually airway. And then we've already exhausted the ENT route. Okay. And that behaviorally they can. So as far as like what we do is, so I typically do like an upper expander that is 3D printed. So then it's very easy and very quick to put it in. On the lower, I typically do a crozat because we want to upright lower teeth if they're rolled in, so that we can maximize expansion to actually see some improvement in airway and then also like just nasal breathing and then also room for teeth to come in. And then what I'm telling them is typically like in my practice, we're going to keep this as simple as possible. Okay. And we're going to put the lower crozat in. The lower crozat, if you don't know what this is, it's just I call it my paperclip appliance. That's not what it is, but it's a bent wire that is made by lab and it snaps in. You can eat with it. You can't eat like super chewy things, it'll dislodge, but it gently broadens the lower. You do not need to expand a lower mandible
And
usually.
that's all over the internet. So we need
Okay.
to expand the upper and lower jaw. And what I tell
Okay.
families and what you just said, we are truly expanding on the sutural level, the upper jaw. On the bottom, we're uprighting teeth, and because they're actively growing, we can get that alveolar housing to go. So it's
You got
really
it.
kind of a fear-mongering tactic, in my opinion, when you hear you must expand the lower on the internet, because it's like, well, we're also expanding it when we're orthodontically uprighting teeth because you're not
Yeah.
truly expanding it. You're expanding the outer surface. It's different than expansion on the top. I think that's where parents get a little hung up too.
Totally. Yeah. We have this conversation a lot. And it's not necessarily wrong to use a lower expander. I don't like them because they are very rigid forces. Expanders were made to be rigid so that the forces on the upper can be transferred to the bony growth suture and widen the actual bone, just like Dr. Turner said. So a lower jaw does not need to be expanded ever. And in fact, you can't expand it. Now, well, I shouldn't say never, right? There's research and
Hmm.
but let's just for sake of this conversation, we are not expanding lower jaws. We're uprighting teeth. We're broadening the lower dental arch. And if someone uses expansion, it gets confusing because orthodontists, sometimes we say we expand an arch, but it's very different. You're not expanding a bone. Okay. So we're using a crozet to broaden the lower so that then the lid has to fit the Tupperware, guys. The upper teeth and jaw need to fit the lower. I think a mistake I see a lot of people make when they are not focused on this whole system is they'll just expand an upper jaw. Now, if there is a crossbite on both sides, yes, expanding just the upper could be warranted. You may not need to upright the lower. But in so many cases that I see these days, lower teeth are a victim of a small upper jaw. They
Hmm.
get rolled towards the tongue. We call that lingually rolled in our field. They get rolled towards the tongue, and that's why you see crowding already develop on the lower. So we have to really maximize the upper jaw and how wide it should be, not over expanding it. That's a whole nother conversation, but expanding it so that the teeth have enough room to come in. Expanding it also because the cranium on a really small kid, you can't expand them into an adult jaw. You don't
Exactly.
want
For your
to.
4-year-old, you can't expand them to a 12.
You shouldn't expand
Yep.
them. The hope is that you expand, you make their anatomy good. We make sure that the inflammation decreases, whether that's naturally or through environmental or ENT or other aspects, making sure that there is passive airflow. Then, if we need to also do myofunctional therapy after expansion to now like get the tongue muscle strong,
Mhm.
that tongue's got a job to do. After we're done with these little phase ones that are, I tell them it's typically about 9 to 12 months. Typically on the really young kids, 4 or 5, we're shooting for a jaw change, not necessarily teeth change. Usually they don't have like adult teeth coming in much, or if they do, they straighten out after we're just broadening the lower and expanding the upper. So I usually don't even put a retainer in. I recommend myofunctional therapy so
Mhm.
that then the tongue can keep developing because I don't want to restrict their upper jaw. I don't want to hold it there. I really want them to get more on track than
You
they
get that
were.
question from parents a lot. Like, what about a retainer? And it's like, no, no, no,
Oh,
you're a
yeah.
grown-up. You need a retainer. Your child needs to keep
Yeah.
growing. They're still not done.
Yeah. So a traditional phase one, when they're like more like 7 to 9 or 10, I will usually do an upper retainer
Yeah,
because
because you're
their
preserving that
tongues
space.
and their
It's
tongues usually not, they're just, yeah, it's like not worth the risk to just to lose all that expansion.
And
So I'll,
most of their growth is done at that point, right?
yeah,
Like
yeah,
there's such a huge jump from 4 to 7. And
huge. Yeah.
it's so that's, I'm sure one of the things that you talk about is like you're getting the growth on track, but if it's not back on track or it can't self-correct, then we're probably going to need to do more work. Like there's
Yeah.
going to need to be another round. But that's the hard part too for parents to understand. They're like, well, little Johnny next door didn't need an expander. And it's like, well, little Johnny had big spaces between his teeth. And little Sally has crowded baby teeth. Like they're different. And how
Yeah.
many of these kids that you see, I see this a lot where they're really small in stature. And my suspicion is that a lot of them aren't because they're not sleeping well. They're not secreting human growth hormones. So they're just not growing to their full potential either. So it's this whole cyclical thing and it's trying to just break the cycle wherever we can. So it's tough.
Yeah. I think the big thing to note too is it's not that we're necessarily aiming for perfection. Like, a lot of these kids are so far going in the wrong direction. And then genetically, you're looking at their parent and you're like, okay, there can be a huge genetic component to this as well. So it's,
We hear that a lot in the tongue tie space too. Well, they had the tongue tie release and everything went really well and we breastfed for 4 years. Say, well, you controlled what you could.
yeah.
But the fact is we're mating and our genetics are going in a different direction as we continue to evolve. So we can't control certain factors. We can only control what's in front of us.
And I think ultimately, when we're looking at the more practicality aspect of all this, is we want to prevent just letting this growth just go wild and being irreversible. And then now the growth is done, and the only way to change airway later is by surgically moving jaw structure or doing MARPE. It's
And that's
harder.
going to
It's
be
much
our part
harder.
two, guys, because your whole story, like why did you get into thinking
Mhm.
you were treating a lot of complex adults and seeing the challenges that they go through, and you're like, how could I
Yeah,
fix this earlier? Like the goal, I think, a lot of the times is to prevent surgery. Like a
it
lot of
is.
these kiddos, you can already see, I can see it at birth. I suspect this child is going to need X, Y, and Z when they're 30 years old
It's
because
to prevent massive
it's hard.
irreversible.
Yep.
Yeah.
We
Try
have
to
a
just
sick population. It's tough.
so many people's so, I mean, it's just so many people's jaws are off, just like so many people have pre-diabetes these days. It's a similar thing. It's just, it's not everyone, but it's a large majority of our population. Our jaws are small. That's why wisdom teeth can't come in anymore because there's no room. So, I think the goal is get a child as healthy as they can be, like get them to be thriving as much as they can be. Of course, it's not just orthodontics, it's not just dentistry, it's not just ENT. There's a lot that goes into this. There's a lot of interdisciplinary providers. Okay.
Yep.
This
I
is
tell people the
truly,
functional med, the mental, and the structure. Like those are the big, because the
yeah,
functional med piece is so underaddressed.
yeah,
It is outstanding what our bodies are trying to fight. It's
totally.
tough to see. It's tough to read about. It's tough to see in your kids. Like, whoo,
Well,
it's
even the microplastics,
yeah.
the
Oh my
article
God.
that came out, I don't know if you follow
My kids
Peter
are full
Attia.
of BPA.
It's just everywhere. It's
Yeah.
everywhere, and that creates inflammation. So
Yep.
you can't change everything. You can't fight everything. You've got to be practical too. We live in society. We're not Neanderthals living in nature, hunting our
Mhm.
food. So, some of this, I think you just have to understand, though, the heavy hitters are really like what Dr. Sterner just said. Like, you got to get the structure as on track as you can, and it may not be perfect. You got to then address the other aspects to open up the nasal passageway and then the pattern of breathing, and that's really it's those three categories really: inflammation, structure, and neuromuscular. And then
Yeah,
there are outliers too, but those are the main.
because you're working a lot. I mean, you get a ton of referrals from dentists. You get a ton of self-referrals. Some of the other major players kind of in your interdisciplinary pool are going to be surgical, orthognathic, ENT, myofunctional. Do you get a lot of
Allergists,
referrals from pediatricians at this time?
no,
No, us either.
none.
It's tough.
None. And
Yep.
that's the other thing too. I mean, even ENTs too, ENTs are not They're not airway trained. Sleep medicine is a
They're
totally
not dental
different
trained.
specialty.
They don't know occlusion. Like they don't know what a class two is. They don't know what a, how it's impacting, and it's within their guidelines to address this when it's impacting craniofacial growth. And for, differences in orthodontics and pediatrics, American Academy of Pediatric Dentistry recommends intervening on a crossbite at age 4, whereas orthodontists still, it's like, well, they're not 7. Not 7 yet. So there's just a bit of a disconnect amongst professionals, and
Yeah.
I don't think there's right and wrong. I think it's looking at cases individually. Like
Yeah.
you are, like your algorithm, it's there, but it's also case specific. It's not like, oh, well, you're 4, so we have to do this, and you're 6, so we have to do this. It's very, very patient centered.
Absolutely. Absolutely. I think just, I think for the lay population, my passion, and I think yours has always been like, we want people to kind of understand more of the legitimate knowledge that is out there, because believe it or not, I hear all the time in the orthodontic world, well, there's not research to prove this and that. And yes, like, and back to Peter Attia, and I'm sorry for referencing him so much, but he talks about medicine 3.0, and ultimately, you want medical dental knowledge to be really founded on research and legitimacy. There is also a whole other world though that can take off in air, especially in airway, that is illegitimate and not research based at all. And there's not like fundamental, foundational, true, well, what am I trying to say? Like it's not founded on science. And I think it's important to found what we do on science and our clinical experience, but it needs to be coming from the right people, right? People who understand and seek out this knowledge. So if you look at 20 different pediatricians and you're getting your information from someone who doesn't seek out the science and the knowledge, but they're giving you a recommendation, or same with an orthodontist, or same with a dentist, or Instagram. If you're on Instagram and you're following someone who is not actually like a practitioner who really founds the information they're giving you on science and the legitimate knowledge that we do have from articles, I think you have to be careful. You have to be really careful because there is a lot of misinformation out there.
Yeah. Well, and it's kind of finding the medium, right? Because we can't say, oh, and I tell people this all the time. I say we can't take a child who has a tongue tied to the tip, who's not feeding and losing weight and his failure to thrive, and say, you know what? Let's put this in our sample size and see in our sample of kids that we're going to address when they're 3, and see if they have speech issues. It's like we can't withhold beneficial treatment when it's there and it's available. So to get the numbers to publish papers and to isolate for other factors is near impossible. So we've got to go evidence guided. You have to find people that are following literature. But if we're asking for sample sizes of, 10,000 people to say, oh, well, this is going to cause this and only this, it's just not going to happen, and it's not going to happen anytime soon.
Yeah. So it has to be founded on research,
Hmm.
but as you said, evidence guided based on like clinical experience. I have the quote because I like the way Peter Attia words it, because he talks about like he's a really good blend of essentially balancing the research and versus like the clinical experience that also you have to make decisions from, because you cannot research everything, especially when it involves every system in your body. But that's okay. I probably can't find it. So,
Well, we'll find it and we'll put it in the show notes because it's a good one. I know what you're talking about. Well, this is so fun. I'm so grateful for you we live in Denver. We're really, really lucky. When I think about the fact that I'm able to be someone's second opinion, you're able to be someone's second opinion. Like there are a lot of people that don't have access to any opinions because there's not even anybody within 100 miles. Like we are so lucky to be in such a progressive area, and to still think that it's a climb is challenging, because you think of how many people in our population. I was actually in Las Vegas this weekend, and all I could do was go around and look at faces. I was like, "Oh my." Like there's definitely been surgical modification there, and there, and these people all need surgical modification here, and here. So it's just fun to like look at a population and think we're just a hodgepodge of different, but there needs to be better decision making when we're young to help us be healthier, because
at
there's a
least
lot of
giving
not
people
healthy.
people options. Yeah. Like,
Yeah, for
hey,
sure.
this is heading in the wrong direction. If you want to intervene, There are options.
Well, and you see that in adults a lot, right? Like, I mean, I hear from parents a lot, well, I didn't breastfeed. I didn't do this. I didn't get my tonsils out. I didn't do that. And I turned out fine. And then you look at the parent and you think, ugh, I don't think they know that they're not actually fine. Like you're kind of you can witness the breathing pattern of somebody sitting in your operatory, and you gotta suspect that there's and oh genetics. My everybody in my family has sleep apnea, so I'm gonna have sleep apnea too. My kids are gonna have sleep apnea too, and maybe that's the case. But like let's at least try to prevent something with the
Yeah.
yeah we have dental tools in front of us.
Yeah, for sure. And I think for me, like my why, and maybe I'll end it with this is again, back to treating all these crazy complex adults is I do a lot of orthodontics to set up for jaw surgery, and we do a lot of adult expansion, MARPE. And it's wild because we try to be so thorough in our consultation to really understand the human, what they're desiring, what they feel that their problems are. But it never fails that after we do jaw surgery on somebody, my surgeon does it. I do not do the surgery, but we do surgery to idealize the jaw structure, the airway, the bite. Everybody says the same thing. They're like, man, once they heal, give them a few months. They say, I had no idea. I had no idea on how poor my breathing was. I had no idea how much my poor quality of sleep was impacting how I felt every day. And afterwards, they're like, I feel so good. I mean, of course, there's surgery, healing things you have to get through, but people who have really poor airway. Now, if they didn't have a poor airway and just a crazy jaw anomaly, then maybe it's different. But most people just have come to get used to whatever they've lived with for their entire life and all the compensations that we do on a regular basis. And that's okay. And not everybody needs jaw surgery or major invasive interventions. But I just do find that so many people feel so much better and their day-to-day life just feels like a lot of I think their emotions get better and they're happier because they can breathe better. And again, if that's what their problem was, I'm not saying everybody needs that.
Well, there's CPAP as an option, right? Like you use
Yeah,
CPAP, your blood
sure.
sugar gets better. You get jaw surgery, your blood sugar gets better. Like it's about sleep. It's about oxygen.
Yeah.
And if we say a lot, like, you've got a lot of options here, and it's really what's choosing what's right for you. But at the same time, if you do nothing, you're not going to get better. And if you want an option to become that appliance, to become that mouth guard, to become that CPAP, it could be through some form of orthodontics. It just can take a little while to get there, and there's some big decisions to be made, but they can be life-changing for the right reasons. So, well, thank you so much. It's been such a pleasure. I will link Dr. Vanderstelt's information and her Instagram and her website in the show notes. Thank you so much for joining us on No One Told Me, the Airway Health Connection. It's fun because now that I hear it all the time. Well, nobody told me. And I think, well, I'm glad that we have this name for our podcast because it's constant that we hear that. Well, nobody told me that it could be like that. So
So true.
thank you so much, Dr. V.
Thank
And we'll
you.
talk soon.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this. And don't forget to subscribe.
want to learn more about airway health or connect with our team?
Please visit our website, untetherediairwayhealthcenter.com, or follow us on Instagram @untetheredairway.
Until next time, bye.